sympathetic innervation, mainly sympathetic innervation. Okay? As you see here, the picture depicted the prostate anatomy. It's just like you feel the real bladder as you see the prostate urethra is growing. Okay? And the ejaculatory duct is just as you see here. So this is the prostate, and this is the prostatic urethra. Ejaculatory duct that originating from the and mid part of the prostatic urethra. Here's the same. Here's the opening of prostatic ducts. Here is the opening of ejaculatory duct within the structure called veromontana. Okay, it is that's located within the prostatic urethra. These are the lobes of prostate. This is the membranous urethra, as I said. Which is the same. What about the review of prostate anatomy? We have actually two classifications based on the zonal anatomy, which is by McNeil in 1981, that classified prostate into fibromuscular zone, anterior fibromuscular zone, transitional zone just around the urethra, periurethral from its name, and the central zone in which the ejaculator is traversed, and this is the peripheral zone where the prostate cancer is arise. Okay? Another classification for the prostate anatomy based on the Lowesley that classify the prostate, that divide the prostate into lobes. We have lateral lobe, anterior lobe, and this is the urethra, you see, middle lobe, and the posterior lobe. Okay? This is much easier than the first one. Let's move to the histology of prostate. The prostate is composed from mainly three structures: thin fibrous capsule over it, the stroma within it that's composed from smooth muscles and connective tissue, and then the epithelial glands that opens it into posterior urethra. طبعا حنبلش بالشيء المهم، موضوع اللي بنشوفه في كل urology clinic. We have many cases of benign prostatic hyperplasia in our clinic as this disease of elderly. As you see here in the picture on your left side, this is the normal prostate, normal bladder, normal anatomy, or the urethra is open. Whereas in your right side, this picture reveals the benign prostatic hyperplasia, external compression over the urethra, causing bladder outlet obstruction, and the secondary ultrastructural changes of the bladder in terms of the nutritional hypertrophy. هنحكي عنهم in detail كمان شوي، زي ما شايفين compressed urethra and bladder is completely different from normal. So the incidence of epidemiology is the most common benign tumor in males of aging. As the man is going more and more, the probability to have a BPH is more and more. Okay? As you see here, it's obviously seen around 90% of men at the age of 80 and more, they have benign prostatic hyperplasia. So if you have a relative with benign prostatic hyperplasia, so by the way, it's a hyperplasia rather than hypertrophy. There is a small element of hypertrophy, which increases the cell number, but the dominant process is hyperplasia. It's increasing in cell number. Okay? If you have a relative with benign prostatic hyperplasia, does that increase your risk to have a disease? Yes, definitely. You have 4 times risk to increase the 4 times risk to have benign prostatic hyperplasia, especially if your relative has a prostate surgery before the age of 60. يعني بيكون عنده severe disease. Usually it's inherited as autosomal dominant trait, but there is no specific gene identified for BPH. physiology of benign prostate hyperplasia is not fully understood till now. There are theories suggesting that it's multifactorial disease. Endocrine, inflammatory process, and growth factors all play an important role in benign prostate hyperplasia. One of the main mechanisms is the endocrine. كيف؟ هلا with aging supposedly with aging the men testosterone level should be decreased, and you know that the prostate fuel is the testosterone. وليس هيك الرجل التستوستيرون بخف المفروض البروستيت تصغر. فشو اللي بصير التستوستيرون with aging the estrogen level will become more and more. So this will increase the sensitivity of androgen receptors over the prostate. So على سبيل المثال انه كان عنده 100 تستوستيرون وهو يونغ بيشتغل از 100. اوكي لما يكبر مثلا صار 10 تستوستيرون بس 10 بصيروا كألف. اوكي لان الاندروجين ريسبتورز of the prostate is increasing and hypersensitive, become hypersensitive. فهذا شو اللي بخليهم hypersensitive؟ الاستروجين ليفل. اوكي عشان هيك بصير البروستيت شريهه لما with aging. اوكي So this is how testosterone excels effects in epithelial cells and stromal cells as well. طبعا testosterone تدخل على epithelial cells binds to androgen receptor and the DNA will be transcription into the growth factors will be produced, transformed growth factors, like growth factors and many different factors, many growth factors that secondly lead to prostate hyperplasia. Testosterone enters the stromal cells via the 5-alpha reductase. It's being converted to a dihydrotestosterone, which is 10 times more potent than the testosterone in its effect. I mean, the dihydrotestosterone bind to the androgen receptor بعدين بتصير growth factors. طبعا dihydrotestosterone produced peripherally by type 1 and type 2 5-alpha reductase. Okay, there are two types. The one that's present in prostate is type 2 5-alpha reductase, whereas type 1 presents in the skin and the liver. Okay. I تذكرون نقطة عشان نحكي عن drugs كمان شوي. So what about the pathophysiology? Patients with benign prostate hyperplasia mainly present with obstructive symptoms and irritative symptoms. اللي هم obstructive صاروا يسموهم voiding symptoms, والirritative symptoms صاروا يسموهم stirred symptoms. Okay? The obstructive due to prostate itself in terms of hesitancy, straining, pulsing, intermittency, sternal dripping, incomplete emptying, with the underlying mechanical and dynamic components, whereas secondary symptoms is due to increased blood outlet resistance. كنت شو مش شغال ولا صح؟ مش شغال. طب في حدا من الشباب ولا شو؟ ما في. بدي ما بماله. مش شغالين لحد الآن. مش بدنيين انتو؟ عادي it's fine. So secondary symptoms due to blood outlet increased blood outlet resistance. بصير عند المريض irritative urinary tract symptoms, irritative LUTs, low frequency and purely urgency, plus minus urgent incontinence. We'll talk about them in detail in the few coming slides. Let's start with obstructive symptoms. Due to prostate symptoms, this is the most common. كل مرضى BPH due to obstructive LUTs. Mechanical component is due to enlargement of prostate. This is mechanical. So due to enlargement of prostate, into a urethral lumen or bladder neck leading to a bladder obstruction. زي ما شفنا قبل شوي بالصورة البروستات enlarged and exert external compression over the urethra بتسكر. Here is the effect of 5-alpha reductase inhibitor اللي بنعطيه واحد من drugs that's used commonly in BPH, which is 5-alpha reductase inhibitor that prevent the conversion of testosterone to dihydrotestosterone. فبصير البروستات it gets smaller in size after 6 months of continuous usage. Okay. فعندنا type 1 type 2 فينا selective inhibitor for type 2 للبروستات لحالهم. في new drugs نازلين جديد يعملوا inhibition للدihydrotestosterone type 1 and type 2 أزمة. فهذا more effective. Dynamic component is related to a stromal element. these smooth muscles and collagen of prostate, which is supplied by sympathetic nervous system, means it's rich in the adrenergic receptors اللي هو الالفا receptors اللي كنا عاملين شوي. ليش بنستخدم هون بنستخدم الفرق اللي هو الفا receptor blocker. Okay, medication that block the alpha adrenergic receptors over the bladder neck and prostatic capsule, causing relaxation of bladder neck and prostatic capsule. فبفتح الطريق بدل ما يكون مسكر بعمل decrease للتون. Secondary symptoms due to bladder obstruction or increasing the bladder resistance. Well, basically, once the bladder resistance is increased, so this will cause changes in bladder mucosa and muscle, trusor muscle. The muscle of bladder is the trusor muscle. For example, we see trusor hypertrophy, increase in sensitivity, hypersensitive trusor muscle, cilules, saccules, diverticularly, increased collagen deposition in the bladder wall, and decreased bladder continence. All of these are changes secondary to decreasing bladder artery resistance. And the end result of those, of these changes, are in decrease in bladder capacity and relative symptoms. The bladder are on stiff organ, okay, rather than pliable and flexible organ. زي ما انتم شايفين هون this is a normal bladder. It's obviously demonstrated, and here the prostate UBH, the urethral bladder artery resistance increase, the urethra is blocked, and the secondary trusor hypertrophy. These are somewhat trabeculated bladder متعرجة فيها شوية سيليولز outbouching سيليولز ساكيولز الأكبر شوية diverticules الأكبر شيء. Okay. That are you have to know that these diverticules are devoid of muscles, so it's just mucosal outbouching without muscles. تمام؟ والsensitivity بتزيد، الcompliance بتقل، فبصير المريض عنده كل obstructive and irritative symptoms. فاحنا بنحكي طريق مسكر المفروض يصير عنده مريض obstructive symptoms. ليش بصير irritative؟ Due to structural changes of trusor muscle. These are diverticular, you see. The mucosa outbouching from muscles interlaced fibers. يكون بينهم شوية weak points. لما يزيد البريشر كيف بده يصير المريض يفول؟ عنده bladder resistance يسكر الطريق. يصير increasing voiding pressure. فكل ما زاد الانترفيزيكال pressure شو بصير؟ بصير زي herniation. of the mucosa between the interlaced trusor muscle fibers. The weak points mucosal herniation يسموها diverticular. هاي عندنا مشكلة طبعا في المريض، ليش؟ لأنه بصير هذول once إن دخل اليورين هون ما بيطلع. ما فيهاش مصل. Okay؟ فبصير increased post-void residual feeling of incomplete emptying plus pooling of urine and secondary infection. Okay, UTI. Again, we have what's called how to assess your patient. We have what's called IPSS score, International Prostate Symptom Score, or American Urological Association score. It's the same. Why it's named AUA instead of IPSS score? Because it can be used for females as well. So you know that the females might develop obstructive symptoms and irritative symptoms as well. So how to assess this is a validated questionnaire that's composed from 7 questions for obstructive symptoms and 3 irritative. Document right as history, and you should document that in your paper. I'm good for assessing the severity of disease, for guiding your treatment, and to assess the response of the patient to the medications that you are already prescribed. This table is composed from 4 obstructive symptoms and 3 irritative. Show the obstructive symptoms: the incomplete emptying, intermittency, straining, and pool steam. Like Samarila Khanum in the last 1 month. Okay? With 3 irritative symptoms, related frequency, urgency, and maturity. Okay? And you have, for each point, you have to give points from 0 to 5, grading. Okay? The total score, the maximum is 35 and the minimum is 0. كيف بتقيم؟ مثلا تحكي لمريضك انت have to have an open-ended question for your patient as a history taker. History is allowed. تحكي له آخر شهر حجي كيف هو دفع البول؟ يقول لك والله دكتور ضعيف. كل ما تروح على الحمام يكون البول ضعيف، بقول لك والله دكتور كل ما اروح على الحمام it's always so it's 5/5. If it's nothing, it's not present, 0. If it's half of the times he's going to the toilet, it's 3. More than half of the times 4. Less than half of the times giving 2, and sometimes it's 1. Okay? For each point. بعدين تجمع السكور كامل تشوف out of 35. From 0 to 7 it's mild disease. From 1 to 7, from 0 it's nothing. From 8 to 19 it's moderate disease. And from 20 and 30 to 35 it's a severe. The patient has a severe case. Suppose that your patient is having a urinary retention, acute urinary retention. You should give your patient 35 or over 35. He's having the most severe lower urinary tract syndrome, obstructive urinary tract. مش قادر يقول مرة مسكر. دفع الطوارئ عند acute urinary retention, so 35 over 35. Now, and there is a quality of life. You should be assessed for the patient. From 0 to 6, 0 delighted, يكون مبسوط, happy. 6 يكون terrible, مش قادر يعيش. Okay? Should be assessed, by the way, because it's important in telling your management whether to go for surgery, to keep your patient on medications, or just watch the waiting. Digital examination, how to, you should examine your patient, abdominal examination general, vital signs, and digital examination to assess the prostate size. There is an module, the hardness of prostate, presence or absence of median sulcus. كيف how to assess the prostate size by digital examination? You should go from most lateral to the most lateral aspect of prostate. Suppose that this is the prostate. You should go from most lateral to the most lateral. Okay? Each finger breadth around 10 to 15 grams. Suppose that you put the prostate of your patient, عملت هيك digital examination, حكيت تقريبا it's approximately 4 finger breadth. It's around 40-50 grams. Around approximate estimate. It's not accurate. في شغله مهمة أن البروستات size is not correlated with the severity of symptoms. يعني you might have a patient with small prostate with severe LUTS, whereas on the other hand you might have a patient with very large prostate and mild symptoms. Okay? فمش شرط. ليش؟ لأن أنت بتحس في الديجيتال examination بتحس البريفرال زون. Will DBH arising from the transitional anterior referral zone في النص جاي. And you cannot validate the transitional anteriority. Okay? How to investigate your patient? You should start with labs for sure, which is urinary culture due to infection or hematuria, serum casein, kidney function test, sodium, potassium, uric creatinine. In 10% of patients with PPH, they are present with renal failure. Prostate cystic antigen, total and free, just to rule out malignancy. I think I have details on that. What about the investigations? Imaging, ultrasound, urinary tract, it's our third hand. So every patient present to the urology clinic should have an ultrasound urinary tract in terms of kidneys and urinary bladder and prostate. ممكن تلجأ للسي تي سكان ممكن إذا كان المريض عنده high creatinine level. Okay? Acute or chronic renal impairment should go for CT scan. طبعا كمان blood ultrasound إذا كان المريض عنده hematuria, and hematuria is one of the symptoms of PBH and one of the symptoms of other diseases like TCC of bladder. Okay? Transrectal ultrasound, نعمل عادة نعمل trans-abdominal ultrasound, more convenient for the patient. And متى نلجأ للtransrectal ultrasound? If you want to assess the size of prostate properly, okay, preoperatively. It gives you more accurate prostate size assessment. Transrectal, it's more invasive and it's more inconvenient for the patient. So, patient present with obstructive urinary tract symptoms. What's your differential diagnosis? طبعا, based on the age. If the patient is elderly, the top of the differential is benign prostatic hyperplasia. If you can read young, present with obstructive LUTs, you should think about referral stricture. Referral stricture in terms of fibrosis, okay? Okay, bladder neck contracture, okay, bladder stone be impacted and disimpacted over the bladder neck. Septum work. Septic impaction, impaction while the patient is urinating. Prostate cancer, usually in the advanced age, present with obstructive symptoms. Urogenic bladder again, two types. إذا كان مريض يجي رتب لو يعرف symptoms بشكل overactive bladder urgency plus minus frequency nocturia. إذا كان مريض عنده obstructive symptoms ممكن يكون عنده atonic bladder، يعني bladder ما بتفضي مشلولة atonic or hypotonic or BGB obstructive urinary tract symptoms. The same picture as BPH. Okay. Urinary tract infections, cystitis, proliferative LUTs, carcinoma of bladder, PCC of bladder بيجي عادة بإريتاتيف urinary tract symptoms as well. ممكن يجي obstructive، ممكن إذا كان bladder cancer وين جاي؟ البلادر neck عامل obstruction. Okay. What about the treatment options of BPH? We have three options: whether watchful waiting, medical therapy, or surgical management. Watchful waiting, we may use it in case of mild symptoms that does not affect the quality of life of patients. ممكن نستنى عليه. We can intervene when symptoms became worse. طبعا ندخل medical therapy بعدين. Again, I have two medications that usually prescribed for patients with BPH. Again, alpha blocker and 5-alpha inhibitor. The alpha blocker works on stromal element that causes diameter obstruction. حكينا عنه شوي. Relaxation of smooth muscle of prostate capsule and bladder neck. طبعا all generation كانوا non-selective alpha blocker. كان عندهم side effects كثير. حاليا صار في selective أو highly selective alpha blocker, alpha 1A1 blocker. That's mainly present in prostate smooth muscle and bladder neck. شو الأمثلة عليهم؟ الألفا بلوكر اللي هو التامسيلوسين والألفازوسين اللي هو الأمثلة على الألفا بلوكر. شو السايد افكتس لهم؟ طبعا لازم تعمل كونسلنج للبيشنت قبل ما تعطي الميديكيشن انه يحكي له نيورومايد ديفلوب بلا 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 بلا. اوكي؟ مش يجيك بعد يومين يقول لك دكتور شو اللي عملت فيه؟ الجوله والله عاده دكتور انا مثلا اخذت الدواء امبارح صار معي ريتروجريد ايجاكيوليشن ما طلع شيء ايجاكيوليشن. سو ذيس از ون اوف ذا كومن سايد افكتس فور الفا بلوكر. الهايبوتنشن especially not selective high selective بيعملوا قليل الهايبوتنشن. فعشان هيك احنا عادة بنفضل نحكي للمريض لما ياخذ الفا بلوكر ياخذه قبل ما ينام، لانه اذا بده يصير هايبوتنسيف بكون هو نايم اوكي بشوفه صاحي. Floppy iris syndrome which is happening during cataract surgery, so it's better to counsel those patients who are going to do cataract surgery to stop alpha blocker just at least 2 weeks before surgery, at least. Okay? Asthenia, dizziness, and rhinorrhea are one of the minor side effects of these medications. 5-alpha inhibitor finasteride اللي هو الالفا 2 اللي هو 5-alpha type 2 inhibitor. فينا dutasteride which is type 1 and type 2 inhibitor, more effective. حكينا preventing conversion testosterone to hydrotestosterone, easing the prostate size around 20% of its original size after 6 months of continuous usage. متى بنستخدمه as a combination therapy? The main drug is alpha blocker. متى بنضيف ال 5-alpha reductase as a combination therapy when the prostate size is more than 30 grams. زمان كانت the guidelines more than 40, and more than 30 grams it's better to start on combination therapy. Two side effects of 5-alpha reductase inhibitors, finasteride, dutasteride. بيعمل decreased libido, decreased ejaculatory volume, impotence, erectile dysfunction, and decreased level of prostate around 50%. يعني جاك مريض عملت له total PSA as lab investigations, as you are investigating your patients, لقيت ال PSA عنده 3. طبعا total PSA لازم يكون normal إنسان فوق. 3 is normal. ما أخذتش منه history، لازم تسأل السؤال شو بتاخذ medications؟ قال لك أنا باخذ finasteride صار لي سنة. So you should correct the total PSA to 6. You should multiply it by 2. فعشان الفينسترايد بخفف ال PSA نص بعد 6 أشهر من استخدامه. مريض صار له اكثر من 6 شهور ماشي على الفايبر بيل لازم تضرب التوتال بي اس اي باثنين، اوكي؟ يعني لما يكون 6 it's completely different from 3. You should investigate your patient regarding prostate cancer. Okay? هاي شغله مهمه. طبعا surgical intervention for the prostate is transurethral resection of prostate TURP, which is the most common surgery worldwide regarding the prostate. Simple open prostatectomy or laparoscopic or robotic prostatectomy. Hello. Yeah, hello. سيب صار شو صحيح؟ Okay, so we have a hormone manipulation of prostate, we have transurethral vaporization of prostate, transurethral microwave therapy. Again, the prostatectomy we have an open laparoscopic or robotic prostatectomy بنشيل الادينوما. Okay, ما بنشيل كل البروستيت. Not radical, it's adenectomy, simple. Transurethral resection of prostate حكينا اللي هي most commonly used. شو absolute indication for surgery? Once the medical therapy has been failed, recurrent urinary tract infection secondary to bladder obstruction, recurrent hematuria, fracture renal retention. شو يعني fracture renal retention؟ يعني مريض اجاك على الطوارئ عنده acute renal retention while he is on medication. اوكي؟ شخصته حطيت له بوليس. خليته على الميديكيشن كمان اعطيته كمان مول 4-5 ايام. شفت له البوليس رد غاب يوم رد رجع acute renal retention. So failure of trial of void at least once is called refractory renal retention. يعني متكتم معه he needs surgery. Renal impairment and bladder diverticularly bladder stones to secondary to bladder to BBH. All of those are indications for surgery. This is how to do TURP while the patient is lying. Intervention, endoscopic manipulation. نقشر البروستيت نشيلها بصير ندص منها checks حتى نفتح الطريق. Two complications of TURP. We have an early and late complication. Early زي bleeding. طبعا البروستيت is high vascular organ. ممكن يصير bleeding intraoperatively. Infection UTI, TUR syndrome. شو TUR syndrome؟ احنا بنقص البروستيت نستخدم hypertonic solution. Okay? So once you are resecting the prostate checks, you are opening the venous channels, venous beds. كل الhypertonic solution get inside the venous channels, the venous beds هذول بيدخل على blood stream. فلما تشتغل عشان هيك عندك TURP عندك limit 60 to 90 minutes it's your limit. Beyond which the TUR syndrome is increasing. So suppose that you are operating for more than 90 minutes, so the probability for TUR syndrome will become higher and higher. اللي هي بصير عنده hyponatremia, delusional hyponatremia. بدخل hypertonic solution على البلد فبصير hyponatremia، بصير عنده مريض nausea, vomiting, obtundation, decreased deterioration level of consciousness. كل هذول دلالة على انه المريض عنده TUR syndrome. Late complication, retrograde ejaculation, in 70-80% of cases is irreversible. ليش؟ نحن بنقص البلادر نيك. على البروستيت جاي على البلادر نيك، نحن بنقص البلادر نيك. ليش؟ شو اللي بيحافظ على anti-grade ejaculation؟ هي bladder neck closure. Once the bladder neck is resected, it's kept open. So the patient will complain from retrograde ejaculation due to bladder neck resection. Urethral stricture, fibrosis, incontinence involved in sphincter while you are resecting. الsphincter بيكون قريب منه. And rectal dysfunction لأنه نستخدم إحنا electrical current while we are resecting فممكن تأثر على nerves there. Okay, the second topic in this lecture is about prostate cancer. It's the most common cancer among men in the United States. What about in Jordan? It's ranked around, it's fourth most common cancer after colorectal and bladder cancer. It's comprising around 9% of cases among Jordanians based on the 2018 cancer history of Mr. Firth. Sure risk factors in prostate cancer, there is no weak age. Aging is the risk. There is no weak age for prostate cancer. Black affected more than white. Family history, obesity, high fat intake, exposure to caffeine, and smoking, as you know, is risk factor for all cancers. Vasectomy, it's a controversial issue. There are some articles reported that the vasectomy is one of the risk factors for prostate cancer, whereas others does not report that. The protective factors طبعا ما في conclusive studies عليها، أنها هاي كلها عبارة عن protective factors against prostate cancer. في عندنا lycopene that present in cooked tomato, selenium, omega-3 and vitamin E proposed to be protective factors. 95% prostate cancer are adenocarcinoma, arising from glandular element of prostate. في other cancers ممكن like TCC, which has a poor prognosis, neuroendocrine, sarcoma, lymphoma that has an heterogeneous root, it metastasizes to the prostate. 60-70% of prostate cancer is arising from the reference zone. So that's why DRE can detect the prostate cancer easily by doing digital examination. Metastasis of prostate cancer, the main landing zone of prostate lymph nodes into obturator, internal iliac and external iliac lymph nodes. The organs, the first organ that has been metastasized to is the bone, especially lumbar spine, the bats and plexus. طبعا شو اللي بيميز الميتاستاسيس of prostate cancer على other cancers؟ أنا osteoblastic lesion، okay؟ عادة تكون osteoblastic, whereas other cancers osteolytic. Other organs ممكن طبعا metastasize to lung, liver, adrenal, and central nervous system. This bone scan shows in a super scan all of these black dots representing metastasis. You see? كلها عبارة عن bone mets. It's a super scan. Symptoms of prostate cancer عادة بيجوا asymptomatic in most of cases. But they be obstructive and irritative symptoms once the patient has an advanced disease. Due to back pain, can do bone metastasis, cardiac syndrome due to spinal cord compression, which is considered as emergency due to metastasis as well. Two signs of prostate cancer, digital examination for your patient. What you can see, what you can palpate is the hard prostate, nodular, loss of median sulcus, irregularity of prostate. All of these signs are indicative of prostate cancer. طبعا نشوف lymphedema in our lips indicate that prostate cancer is metastasized to the lymph nodes, causing blockage of those lymph nodes. Hyperreflexes of lower extremities if there is a metastasis in the spinal cord. Okay. طبعا how to diagnose patients with prostate cancer? After taking a history of your patient and examining your patient, you should go for total PSA. This is prostate-specific antigen, that's Syrian protease enzyme, produced from epithelial cells of prostate, can be secreted from benign and malignant tissue. It's circulate free, and most of them are bound to the protein alpha-1 antitrypsin. The dominant one is bound, the minority of it is circulating free. The half-life of it is around 2 to 3 days. It has 50-70% sensitivity, but it's not specific. يعني it's an organ specific but not disease specific. يعني جاي مريض امبارح عنده total PSA 12. عالي ولا مش عالي؟ عالي. بس المريض عنده severe irritable bowel symptoms, signs and symptoms of prostatitis. ممكن تعمل هيك؟ مش شرط انه في high PSA is prostate cancer. ممكن infection يعمل prostatitis، ممكن تعمل في high numbers. prostate طبعا less than 40, less than 4 sorry, nanogram per ml is a normal PSA. From more than 4 it's considered as high. في عندنا شيء اسمه gray zone or gray area from 4 to 10. More than 10, the probability of prostate cancer is higher and higher. So ما في عندنا normal range of prostate. لأنه ممكن prostate cancer يجي بأقل من 4 ممكن. بس أنتوا as medical students undergraduate, you can consider the cutoff point is 4. Less than 4 is normal. More than 4 يصوتوا مقيمين مسالك أخطاء مسالك ما يحتاج نحكي details. But more than 4, it's abnormal. You should rule out prostate cancer. Less than 4, it's normal. طيب عندنا المريض that total PSA from 4 to 10. This is a gray zone. How to increase specificity that the patient has prostate cancer rather than BBH? We have to measure the PSA velocity, PSA density, and PSA ratio for the patient. دلوقتي كيف نقيسها؟ كيف تتطور ال PSA؟ كيف بزيد؟ هلا اللي كان ال PSA بزيد more than 0.75 nanogram per year goes to prostate cancer. يعني جات المريض كان 5 سنين الماضية كان ال PSA عنده 5. اوكي؟ عدت له اياه السنة شهر 3 أو 2 طلع عنده 6.5. Within less than a year, ضاعف 1 point something, which is high velocity, goes to prostate cancer. Okay. PSA density, each gram of prostate is producing 0.12 nanogram per ml PSA. يعني, suppose that the prostate of your patient is around 100 grams. But this total PSA is supposed to be 12. We can accept up to 12. So it's size dependent. Marine and 50 gram prostate, we can accept up to 6. Okay. But we can marine and a small size prostate 30 and his PSA is 6 or 7. It's not correlated. Okay. So he's having a very high density. So think about prostate cancer. PSA ratio اللي هم الفري على التوتال. دائما لما نطلب توتال نطلب فري. عشان نحسب الفري على البي اس على التوتال. عادة المالجنت لازم يكونوا أقل من 20% أو 18 بعض الكتب كافيين. يعني كل ما قلت الريشيو كل ما زاد probability of prostate cancer. تمام؟ لما تحسب الفري على التوتال. تمام؟ So what about screening for prostate cancer? According to NCCN protocol, every man above the age of 55 should be screened. Above 45, the patient has a risk factor such as black, ethnicity, family history of prostate cancer. لازم يبلش السكرينينج earlier. شو السكرينينج نعمل PSA yearly or every 2 years أو نعمل digital examination both of them. Okay? Total PSA and digital examination. Other lab tests that you should order, your kidney function test as a baseline, CBC, because in advanced stage of prostate cancer, the patient has anemia, alkaline phosphatase that indicate the presence of bone metastasis is high. How to confirm that the patient has prostate cancer? This is what's called transrectal ultrasound guided biopsy. Okay, you should go for biopsy with a transrectal, the transrectal ultrasound guided biopsy. وصارت النيو era كلها بنعمل transperineal. Okay, we insert a transrectal probe ultrasound inside the rectum and ناخذ biopsy for the perineum. Okay, multiple. عادة ناخذ 12 biopsies, 6 from each lobe lateral ونركز على peripheral zone. Okay. Indication for elevated PSA abnormal hysterectomy examination. It's an invasive procedure. It's done under local anesthesia in the clinic. Sometimes associated with prostatitis and less than 1% of cases that might lead to septicemia and some cases. This is the only way to confirm prostate cancer. Grading of prostate cancer it depends on what's called Gleason pattern, from 1 to 5. 1 being most differentiated and 5 is least differentiated or poorly differentiated. هلا كيف ناخذ biopsy مثل الهistopathologist بقرا لنا اياها بحكي لك انه this patient has prostate adenocarcinoma Gleason score 3+4 لازم نحكي شيء بلس شيء. شو يعني؟ لأول رقم اللي هو الموست common pattern that's seen in the slide. يعني هو شايف انه moderate differentiated 3 هي most common. second most common هي 4 بحكي 3+4. شايف العكس بحكي 4+3. اوكي؟ فهي حسب شو شايف الهيستوباثولوجيست. 3+4 بيطلع 7. 4+3 7. بس انه احسن 3+4 احسن طبعا. اوكي؟ Low grade, the patient has a decent score 6 and less, 7 is intermediate, and 8 to 10 is high grade. We have a new grading system based by WHO in 2016 that classified the prostate cancer into grade group 1. The patient has a decent score 6, group 2 7, 3+4, group 3 4+3, 7, group 4 4+4, 8. Group 5 will be 9 and 10. Okay, 4+5, 5+5. This is the dynamic staging of prostate cancer, 2010. تعرفوه. You know the metastasis and metastasis diseases. What about the treatment of prostate cancer? Based on the patient has organ confined disease or locally invasive or metastatic disease. الأوردر confined متى بنروح على watchful waiting or active surveillance لما كان يكون مريض frail patient يعني lifetime expectancy less than 10 years, he's having many comorbidities, he's elderly, فما بنحضر على risk of surgery أو إجراء نحن watchful waiting أو active surveillance. watchful waiting بيعملوا شيء، active surveillance بيعملوا كل سنة historical examination and total PSA. okay شوف إذا في progression of the disease. The can read he's a good in terms of life expectancy, more than 10 years. He's having, he's for example, good 70s, yani, good 60s. Go for radical prostatectomy. You should remove the prostate or the prostate along with seminal vesicles. نعمل reconnection of the urethra with the bladder neck. غير عن السمبل prostatectomy تبع البي اتش نشيل ادينوما فقط. نشيل بروستيت كامله اسمها راديكال بروستيت مع السيمينال فيسيكلز. اوكي؟ طبعا في شيء اسمه راديكال راديو ثيرابي ممكن اكسترنال بي راديو ثيرابي او الراكي ثيرابي نزرع راديو اكتيف ماتيريالز. كل واحده لها شغلات ديتيلز مش راح ندخل فيهم. بس ممكن نعمل راديكال بروستيت ممكن راديكال راديو ثيرابي. لوكال انفيزيف طبعا there is no role of watchful waiting or active surveillance in this case. You should go for radical surgery or radical radiotherapy. If the patient is having severely advanced locally disease, يعني locally advanced, يعني metastasis to the side walls, abdominal side walls, pelvic side walls, and severely locally advanced, you should treat it as metastatic disease, okay? As metastatic. Metastasis, we have 3 lines of management. First line is hormonal therapy, whether by medical or optically, castration. يعني prostate cancer بنغير عن طريق التستوستيرون، فإحنا هدفنا إنه نقطع التستوستيرون عن prostate cancer, whether by hormonal therapy أو نعمل له biotherapy. Second line is a chemotherapy, docetaxel, and third line new experimental agents اللي هم abiraterone acetate and enzalutamide. شو الهرمون ثيرابي؟ كيف نعمل الهرمون ثيرابي؟ نعطي شيء اسمه luteinizing hormone LHRH agonist or antagonist اللي بيلعبوا على الhypothalamic pituitary reticular axis. Our aim is to cut off testosterone production from the lining cell of testosterone of the testicles. فاحنا نعطي LHRH antagonist نوقف LHRH اللي فوق ونوقف LH secretion ونوقف التستوستيرون. لما نعطي LHRH agonist الاجونست بيمنع السيركاديان ريتم اوف تستوستيرون برودكشن وبصير ستاتيك. هاي الستاتيك ال اتش ار اتش اجونست بيعمل نيجاتيف فيدباك على التستوستيرون، فبخفف التستوستيرون بوصل للكاستريشن ليفل تقبل البروستيت كانسر. اوكي ممكن طبعا هذول هرمون ثيرابي شوي غاليين، جرعتها every month او every 3 months، يعني بيكون معهم مش مصاري بيجيبوا له الدكتور من الكاستريشن هذا نعمل شيء اسمه سب كابسولر او كيكتومي بشيل ستيكولار تيشو اللي هو السورس المين سورس التستوستيرون. اوكي so hormone therapy effect is not durable. After certain period we reach a state called castration resistant prostate cancer. بعد فترة ممكن هاي البروستيت كانسر تسكيب للكاستريشن ليفل في شيء اسمه hormonal resistant prostate cancer. هون بنروح على السكند لاين ثيرابي اللي هم دوسيتاكسين كيموثيرابي او نتيجة overall survival progression-free survival. والثيرد لاين ثيرابي اللي هم ثيرد لاين اللي هو روزالوتامايد اند ابراتيرون. طبعا في شغله بنعطي عاده ال اتش ار اتش اجونست ال اتش ار اتش انتاجونست along with anti androgen. اوكي نعمل شيء اسمه complete androgen deprivation therapy. اوكي من نوقف الاندروجين بالمره للمريض. And that's it. Do you have any questions so far?